In order to perform transvaginal ultrasound, it is recommended to have a transabdominal ultrasound prior to inserting the transducer. For transabdominal ultrasound, we need full bladder, except we are performing it in second or third trimester of pregnancy. Full bladder provides us an acoustic window into the pelvis, but there are some limitations of transabdominal ultrasound. For instance, obesity, inadequate bladder filling, abdominal scarring, recent surgery limiting access, retroverted or retroflex uterus, fibroids, air-filled bowel, which are the gases in the abdomen. This is how we perform transabdominal ultrasound to assess the uterus and ovaries. Once the transducer is at anterior abdominal wall, we will be getting the anterior wall of urinary bladder with urine filled, which is fluid filled urinary bladder, and posterior to that will be the uterus, or if we are looking for ovaries, we will find the ovaries. Once we magnify, we can see this is how on transabdominal ultrasound the endometrium will appear. Whereas transvaginal ultrasound does not require full bladder. The higher resolution scanning with more magnification, it has got better resolution because of the higher frequency which is used, better identification of early and ectopic pregnancies. We can assess the follicular size, small masses, abnormal fallopian tubes, endometrial thickness can be measured more accurately as compared to the measurements which we perform using transabdominal ultrasound approach. This is how the transducer is placed for TVS, and we will get part of uterus. We have to keep in mind that the transducer is like a torch, and the sound waves which are being emitted are like the torch light. So it will be spreading in different angles, and we will be able to visualize the structures which are in front of these sound waves which are emitted. If we compare transabdominal versus transvaginal ultrasound, you can see this is transabdominal. Although the uterus and a sac inside are visible, but if we use TVS, it is better, improved resolution, and we can get better study of the structures which are required to be studied. The first part of this presentation is about TVS instrumentation. What are the instruments which we use? The first thing we need is machine, an ultrasound machine with better resolution, better facilities, preferably having color Doppler, power Doppler, and it will add up a lot if we have power Doppler with 3D or 4D and power Doppler with directional NGO and tissue harmonics. There the second thing which is part of machine is the transducer. We know that the same machine is used for all type of modalities of ultrasonography. We can use same machine for 3D, 4D volumetry. We can use it for abdominal with the convex, even if we need it for musculoskeletal or for small parts, we can use the linear transducer. So the difference is of the settings for TVS and the transducer. The transducer, which is commonly called probe, are of different types. The one which is used for TVS has got three main parts: handle to hold the probe, this area; shaft which enters the vagina, this one; footprint which houses the crystals, this part. For probe preparation, probe should be covered with condom containing small amount of gel. So condom can be of any company or any type. We put some gel, then we put the first condom. This is how we will cover it with the condom. So the two parts, the footprint and shaft, are covered with the condom, with a cover, and we put some gel here so that we can have some media for transmission of sound waves. There are two techniques. One is single condom technique, in which just one condom is placed and a rubber band can be placed on it, so that by moving the transducer, it is not displaced from its proper area. Condoms are tested according to British standards, which mean 4 condoms per 100 may have holes. That is why I use double cover technique. It is preferable, although it compromises the resolution a little bit. So for double condom technique, I have put some gel, then I use one condom. I put a rubber band here, then again gel is applied outside the condom tip and the second condom is used. Again, after the second condom, I will put another rubber band. In patients with infertility, use water as coupling agent, as the coupling gels are spermicidal in action. So if there are patients of infertility, we can use water outside the condom as coupling agent, whereas inside there are 4% chances that this will go through the spores, although the spores are very small, microscopic, and the molecules of gel are bigger than that. But if we are more cautious, then we can use gel on the foot end of the transducer, covering it with the condom, then putting some water for providing aqua, for providing media, covering with the second one, and above the condom we will put some water in fertile patients if there are chances of infertility on that day, or patient had history of coitus about 4 to 6 hours before TVS scan. Disposable gloves should be worn because the meticulous disinfection between uses is required, and papilloma viruses can remain infectious for 48 hours outside the body. So it is better to have disposable gloves to avoid any infection. According to manufacturer's directions, the probe should be disinfected in Sidex solution for 10 to 20 minutes or washed with soap or water. It depends upon the instructions of the manufacturer of machine or transducer. Then after instrumentation, we have techniques. The recommended procedure is that we perform transabdominal scan to have an overview of pelvis by having full bladder. Here is the scanner, the sound waves, then we have the structures. This is vagina, then is the cervix and body of the uterus, then adnexa on the sides with the fallopian tubes and ovaries. Here are the intestinal loops, the rectum. Then after having transabdominal scan, we will ask the patient to empty urinary bladder. We need to explain everything. So full explanation of the procedure is required, leading to consent to procedure. Better to change to suitable gown and ensure privacy of the patient. Then is transducer preparation. Apply gel to cover. Apply cover to the transducer. Smooth out any air bubbles. Air bubbles will degrade image considerably. Apply lubricant. Lubricant can be commercial gel, water, or sterile gel. Patient positioning. Preferably, patient is required to be supine on the couch. Elevated pelvis. We can elevate it by putting foam pad or pillow if no gynae table is available. If we have gynae table, that will be better. Otherwise, we put a foam pad or pillow under the buttocks of the patient. The knees are flexed and suitable drap cover is required. This is the lithotomy or gynae table. The knees are flexed, and if the male radiologist or gynecologist or sonographer or radiographer is performing TVS, female attendant is required. So in radiology department, main sonographers need female attendant. And even the transducer, the probe can be inserted by sonographer or patient herself. This is how it is inserted, and it will be the location. The urinary bladder must be empty. This is the pubic symphysis, the female urethra, and here is the transducer, which remains in vagina. It is transvaginal, means it remains in vagina. It will not cross the external os. It will not go into the cervix. It will not go into the endometrial cavity. So if there is pregnancy, it is not going to enter into the endometrium or even cervix to touch or to abort that pregnancy. So there are many misconceptions. Observe, monitor during insertion. Evaluate vagina first, because you are entering your transducer into the vagina. This will help you for orientation. The head of the transducer, there will be head at the transducer, the part which you are entering, which houses the crystals. So if your transducer head is upward in this direction, you can easily evaluate vagina, and then you will have better orientation of the structures. Remember supine female anatomy. This is the supine female anatomy, the structures behind it. So if I elevate the shaft in this direction upward, I will be able to see the rectum and the spine. And if I move it downward, I will be able to see these structures, which are the required structures. First, direct transducer slightly posteriorly. This is how the transducer is placed, and then it is moved. So the transducer head is upward, and then the first step will be to move it towards the right side of the patient. So the head end will be on this side to get the coronal section. By putting in this direction, first I will see the posterior fornix by moving this shaft upward. Then I will move it downward to see the uterus in sagittal view, in the longitudinal view, and then I will move the transducer in this direction to see the coronal view, so that I can have the right and left concept. This is how we can have orientation, that if the uterus is anteverted, my transducer is in the vagina. This is external loss. Here will be the internal loss and endometrium, fundus of the uterus. This is the head, foot end, anterior side and posterior. And the field of view of the sound waves is represented by this area. This is whole field of view. So we will be easily successful to get a proper view of anteverted uterus. On ultrasound, it will appear like this. So our transducer is almost here in this direction. From here we are looking, we are getting the longitudinal view. This is a scan which was done at 10th day of cycle. Then for retroverted uterus, this was anteverted and anti-flexed uterus, because the flexion is at external os, which is the junction of cervix and vagina, and version is angle between cervix and body of uterus at internal os. So this is anteverted, anti-flexed. Version is here, flexion is here. Here we have retroverted, retroflex uterus. And when we put the transducer, we will move it a bit upward so that we can see the body which is going towards the posterior side. And on ultrasound, on our monitor, we will be able to find this type of view in which it is going towards your right side, whereas anteverted was this one. So long sections of vagina, cervix and uterus for sagittal imaging. This was the sagittal imaging which we saw, this one. So midline endometrium is visible, left and right orientation is possible. Sagittal section of pouch of Douglas is possible, and sagittal section of ovaries and adnexa are. Then are the tips. If we cannot find fundus, make sure probe is inserted far enough. Lift probe handle up for retroverted and move probe handle down for the anteverted antiflex uterus. If you cannot see all of the midline echoes, rotate probe slightly. Cannot find the ovaries, go to coronal plane. So, for retroverted uterus, if this is the uterus indicated by black lines, now my probe is in vagina, I am able to see a part of the uterus, then I will move it upward so that I can see whole of the body of uterus and part of cervix. So it will be visible like this. So it was like this. Then I move the shaft upward so that I can visualize it. It is the technique for retroverted uterus. For coronal section, it appears like this. This is anterior, posterior, right and left. So this will be the right and left of the patient in coronal section. In coronal section, we can see the cervix, pouch of Douglas, uterus. We can have multiple sections like left ovary and adnexa, right ovary adnexa. The tips are for retroverted probe handle upward, for anteverted probe handle downward. For ovaries, pull back slightly, move probe into adnexa. Keep uterine side wall and pelvis vessels in view. Sweep probe handle up and down gently. Apply light pressure on anterior abdominal wall with other hand. So if there are gases, we can put left hand on the anterior abdominal wall to compress it a little bit so the gases fade away. Remove the transducer cover. Careful disposal is in suitable container, which is a dustbin. Wipe probe with soft tissue. Clean with soap and water. Be careful not to immerse handle or cable. Disinfect according to AIUM or ASUM guidelines, which are the guidelines of American Institute of Ultrasound Medicine or Australian Society of Ultrasound and Medicine. They have given guidelines, but be aware of manufacturers' instructions about disinfection also. Withdraw the transducer gently, provide suitable cleaning material like tissue papers. Ensure privacy if she is changing the gown. The next is sonoanatomy with TVS. Here you can see when we are inserting the transducer in vagina, we are able to see part of the uterus. These are the fallopian tubes, ovary, urinary bladder, rectum. So I will move my shaft downward to see this part also. Image orientation by TVS. This is a scan which is done in early second trimester. This is the external cervical os. There will be on this side, this will be the vagina, as the transducer is in vagina. Cervical canal and internal cervical loss. This is placenta and edge of placenta. We can measure the distance if required. Here are some fetal parts and amniotic fluid. So anteverted uterus on grayscale and anteverted uterus on power Doppler. We are not getting colors here or here because the color box is on at a specific area. This is retroverted on grayscale and power Doppler. Here you can see the cervix of the anteverted uterus. This is the fundal side. Here is the fundal for retroverted, and we have the endometrial linings. In coronal view, we can get ovaries. These are the ovaries, the on right and left side. If we get this type of view with color Doppler, these are the iliac vessels and an ovary with a follicle which seems to be almost mature. By TVS, we can also assess the female urethra. This is the urinary bladder and female urethra. We will look at its wall and we can put colors to diagnose the acute inflammation of the urethra. Then comes TVS indications and applications and overview. The advantages are that TVS is having better beam mode resolution, typically 6 to 7.5 megahertz, more accurate diagnosis, high color and Doppler sensitivity, easier to accurately place sample volumes. It is fast, well tolerated. It can also be used as a palpation tool. Disadvantages, it has limited depth of field. Like we have to move it to see the posterior part or the extreme anterior part of the pelvis. It is organ specific. If you want to see the ovaries, it is not necessary that along with the ovaries, the uterus or whole of the uterus will be visible. Limited transducer movements, new transducer techniques overcoming these problems because their head houses crystals and head can even move in some limited angles. Applications are suboptimal transabdominal study in obese patients, retroverted uterus, poor bladder filling, excess bowel gas, and pelvic adhesions. Like here is a case of a female having retroverted uterus and she was obese, 136 kg. On abdominal scan, even the uterus was not properly visible. Whereas by TVS, you can see the gestational sag, the double decilute reaction, this one, and a yolk sac inside. In gynae, we can have applications of TVS like for assessment of endometrium, anatomical anomalies, follicle tracking, uterine masses, adnexal masses, and cul-de-sac fluid. This is the periovulatory phase TVS scan to evaluate the endometrium. There is excretory phase, hyperequic, subendometrial calcifications. These are the calcifications. And here is a polyp, endometrial polyp inside the endometrium. We can also use TVS to assess the anatomical anomalies like the bicornate uterus. One is showing endometrial thickening, the other is having a gestational sac. We can use it for follicle tracking. This is normal ovary with multiple follicles. One of the follicles is larger, then is stimulated and hyperstimulated follicles. We can also use it for diagnosis and differential diagnosis of different uterine masses. These are all TVS scans for carcinoma. Here is a mass, and here you can see by using color Doppler, there is excessive flow within this mass in the endometrium. Trophoblast. Here is trophoblastic invasion, and on power Doppler, excessive flow is seen. AV malformation, mixing of colors showing higher velocities. This is AV malformation. So on grayscale, it will be difficult. If we use TVS with color or power Doppler, things will be more easier and the diagnostic accuracy will improve. Hematometra, then hydrated form mole, and performing sonohysterography for this case, it looked like thickened endometrial cavity. By putting saline through a catheter, performing sonohysterography, we can see the structure which is lying inside, which can be a polyp or a mass. We can use color Doppler to confirm the diagnosis. Adnexal masses which can be detected by TVS includes the pathologies of the fallopian tubes, like here is pus, and it looked like this lake. Here you can see clear debris in the tube. Here is part of the uterus visible. For intrauterine devices, you can use TVS. This is Lippy's loop, and here is its string. PCOS, polycystic ovaries, multiple immature follicles are there. You can see excessive by TVS. On transabdominal scan, the things were not clearly visible. This looked like ovary. But look at this by TVS, which is organ specific. We can find a sure follicle in this ovary, which was not visible on transabdominal scan. This is a transabdominal scan. For adnexa, these structures are not clearly differentiable, and on TVS, we were able to diagnose it as a dermoid cyst. Again, transabdominal scan versus a TVS scan, you can see a very clearly visible dermoid cyst. Here it was by transabdominal, this is transabdominal, this is transabdominal, and by TVS, it is very clearly diagnosed. Then comes TVS uterine assessment. By transabdominal scan, the uterus looks like this. And here we have the anteverted uterus, the endometrium, and you can see the outline very clearly, and normal endometrium. We can use TVS for assessing different stages of the endometrium during menstrual cycle. So when the endometrium is in menstrual phase, walls prominent with blood in the cavity. The walls will be prominent. The wall thickness will be 2 millimeter, around 2 millimeter, and we will get blood inside. Then is the proliferative phase, early proliferative and late proliferative. The thickness is from 4 to 8 mm. Here you can see the endometrium, which is early proliferative phase, and in late proliferative phase, here it is. In secretory phase, hyperechoic thick with a hollow around it at endometriomyometrial interface. This is the endometrium, and this will be the endometriomyometrial phase. It looks like a halo, this hypoechoic area. The size will be 7 to 16 mm as normal. Then is postmenopausal, which must be less than 6 mm. Thin endometrium, this one. It must not exceed 6 millimeters. We can also use TVS for diagnosis of different congenital uterine anomalies. This is arcuate uterus. Then we have aplastic uterus and bicornuate uterus. A large myoma with color Doppler. These are different types of fibroids or leiomyomas. Like this is submucosal, subserosal, intramural, which is within the muscle, which are usually myomas. The submucosal and subserosal are leiomyomas. We can have subserosal pedunculating inside the uterine cavity, which can be named as endometrial fibroid or intracavitary fibroid or pedunculated submucosal fibroid. Whereas the leiomyomas, which are pedunculated outside the body or outside the fundus of the uterus, are pedunculated subserosal fibroids. As the outer line is subserosal, so we have got fibroids here, they pedunculate out. They are leiomyomas because they involve the muscular layer as well as the serosal layer. Similarly, those which are lying below the mucosa of the endometrium, they are submucosal, but in origin they are leiomyomas. They involve muscles and the mucosa, the inner layer. Whereas those which are lying within the myometrium, not involving the mucosa or serosa, they are myomas. As a whole, we call them fibroids, which is not expected from a good sonographer. We have to mention the type, the location, the size of the fibroid. So if my report says it is fibroid uterus, it means I am a beginner in gynecological scanning. But if I'm mentioning it according to the location, size, and type, then it means I know my job. Here is one of the fibroids. Which type of fibroid? we have to look into it. Here is the wall and the outer side. Although we need a real-time view, but at this freezed image, it is one of the subserosal fibroids, which is pushing the serosa on one side. This is another scan in which you can see the fibroids, and here is a myoma, which is inside. If it is touching or pushing, it will be leiomyoma. If it is touching or pushing the endometrium, then it is leiomyoma. There will be indentation of the cavity. Another fibroid here. There is a fetus inside and a fibroid, and this fibroid was removed from here. A case of endometrial hyperplasia and small multiple cysts in the endometrium with hyperplasia. This is the peduncle of the polyp and endometrial polyp inside. This was that polyp. Endometritis, inflammation of the endometrium by TVS. You can see this is giving shadowing. The slides are upside down. There is hematometra, hydrometra, and pyometra, in which you can see the fluid, which can be pus, blood, or an excretion within the myometrium, within the endometrium. Sorry, the endometrial polyp again. This is the feeding vessel, and we can perform its spectral analysis to assess the infection or necrosis, which lowers the resistive index, which is the impedance. We have seen this slide in some of the previous lectures. This is endometrial polyp and its feeding vessel assessed on spectral Doppler. Then comes the endometrial carcinomas, the endometrium by TVS showing multiple cystic areas. On color Doppler, there is a feeding vessel. That feeding vessel can be assessed for the resistive index. If the resistive index is below 0.45, like here it is 0.3, it goes towards malignancy, and we can advise biopsy to confirm it. Intracavitary fluid collection. This is all of this is the endometrium. By TVS, we can see there is fluid with a mass, which was a carcinoma. These are again different slides of leiomyomas, the fibroids. This is submucosal. Then we can have leiomyosarcoma, fibroid having malignant changes. On Doppler, there is excessive flow. We can have more flow or increased flow in a fibroid, in a leiomyoma or myoma, in cases of pregnancy. As with pregnancy, the spiral arteries are straight, the blood perfusion to the uterus and cervix is increased, so the endometrium is increased. So if there is any fibroid, its size will increase aggressively. But in non-pregnant women, if you get this type of excessive flow, then it will be suggestive of malignancy. Then is adenomyosis, ingrowing of the endometrium into the myometrium. The endometrial tissues are grown into the myometrium, and once there is menstruation during menstrual days, these tissues, which are the endometrial tissues lying embedded in the myometrium, will start bleeding, and this is blood inside, they will appear like this. But if we scan this patient during non-menstrual phase, during proliferative or secretory or ovulatory phase, we will not get these cystic areas. It affects 20% of women, mainly multiparous. Symptoms will be bleeding, pain, infertility. Usually the pain increases during menstruation. Findings are enlarged uterus without any fibroid. So even one side of the uterus myometrium will be increased. So if you get a patient with one of the walls seem to be hypertrophied, better to call her back during menstruation. So you will get these spots and the diagnosis will be confirmed. Small cystic areas with snowstorm appearance, molar pregnancy. This is another molar pregnancy, the flow pattern, and we can assess the spectral Doppler. But here, the resistive index will be above 0.5. Here you can see 0.66. We can also find the intrauterine contraceptive devices. We have seen a slide before. These are different types of contraceptive devices. We can measure the distance of the upper part of the device from the fundus of the uterus. So if we put contraceptive device under ultrasound guidance, the accuracy, safety will be far better. So here you can see the endometrium. This is a device, contraceptive device with a gestational sac because it is displaced. IUCD is in the cervix. So endometrium was empty, allowing the gestational sac to embed the endometrium. Endometrial adenocarcinoma, excessive flow on TVS. This was another mass with excessive flow. Leiomyosarcoma with necrotic areas. This was another case, an old image. Here is another mass with TVS, real-time TVS, and adenocarcinoma. Then comes ovaries. In ovaries, we will look for cystic solid ratio, solid cystic, or solid. So these are the four appearances which we can have in the ovaries. This is corpus luteal cyst. A case of serous cyst adenoma, clear fluid, thin walls, mucinous cyst adenoma, cystic areas, we can get small nodule on the septas. If we put colors, we can get some color flow. This is dermoid type of ovarian cyst. Now here you can see the ovary and a para-ovarian cyst. This is ovary and this cyst is lying outside, para-ovarian cyst. This is by TVS more better view of the para-ovarian cyst. Case of endometrioma. This is ovary and endometrioma, a close view of debris-like appearance, thick fluid inside. This is another case of endometrioma. We can also have malignant ovarian tumors. Again, the flow will be more, they will be growing rapidly. We can assess their RI on spectral Doppler. Obviously, it will be above 0.5. Here it was 0.57. Then is the extra-ovarian clear separated cyst. There is a small nodule inside and cyst. The ovary is here, so it is extra-ovarian. This is a gut loop. We can also have peritoneal inclusion cyst, which will appear like this. There is a large nodule originating from the peritoneum with some fluid inside. These are the gut loops. We are using TVS. For free fluid in pouch of Douglas, in order to diagnose any ectopic or even for pelvic inflammatory disease, we look for fluid. Case of hydrosalpinx, which looked like a cyst, ovarian cyst, but this was fluid in the tube.